I was PI of the Imaging Coordinating Center, a similar role that I had in Courage, and with Dr. Weintraub being in trial leadership of both of these trials. And I thought it would be excellent for me to look at the evidence development and how we've come to the development of the ischemia trial design, the preamble and the necessary components from an imaging perspective, a lot of which I think we take for granted today. It culminated in 2012 with the Stable Ischemic Heart Disease Guidelines for chest pain, which focused on the role of stress imaging or ischemia-guided management. Certainly those guidelines are being updated and should be published in 2021. But from the perspective of today, I thought it would be great to see how these pieces of the puzzle, if you will, these pieces of evidence led us to where we are in terms of the ischemia trial and what we continue to learn from clinical trials and our failures and foibles despite 20 years of evidence. And of course, prior to late 90s, most people thought that you could not risk stratify with any kind of perfusion imaging or any type of stress imaging results. It was just felt that a near-term test could not predict long-term wise. And of course, this was one of the first papers published in 1998, over 22 years ago. So for the fellows in the room, they really didn't believe that you could do this. This is one of the first papers that showed that as the extent and severity of imaging abnormalities worsen, so do the rates of death or myocardial infarction. And there were some necessary steps that had to be undertaken for this to work in terms of risk stratification. And part of that has to do with our ability to segment the left ventricle. So to be very quantitative, or at least in this case, semi-quantitative in terms of left ventricular segmentation. So we had an idea of the extent of myocardial involvement, but we also had an idea of the severity of defects within each segment. So this was typical of any score that you use today, in that it looks at both the extent and severity of abnormalities, puts it into a sum score, and that is part of the reason you get this really effective risk stratification. So this was necessary information. Following this, some 5 years later, the Cedars-Sinai group published this looking at SPECT ischemia severity in relation to event rates, in this case, cardiac death rates, in revascularization versus medical therapy. Now, this is a non-random comparison, so we have to be careful with these non-random comparisons because it's not the same as randomization. You can do a lot of different statistical techniques, but you're not going to emulate randomization because in this case, many of the medical therapy patients, we actually don't have any idea about adequacy of medical therapy, how sick these patients were they not revascularization candidates? I think you could go on and on. At or about, these findings suggest that at or about 10% of the myocardium. Beyond that, when you get into moderate severe ischemia, there was a reduced death rate with revascularization. So this was intriguing. I guess that's how I would frame it in terms of understanding these non-randomized or observational findings. It's an intriguing result. And if you left it there in 2003, you would say, oh, well, that's something that we noted a long time ago. Contemporary techniques don't emulate that. But this evidence has continued to accrue, not just the 2003 paper. These same authors published a similar report in 2011, showing that the magnitude of the benefit was greatest when there was less scarring in the myocardium, which makes sense, right? And that those patients that had a lot of scarring did not see that same benefit. But also in a separate investigation just published last year in European Heart Journal from Krishna Patel, showing with PET imaging that same exact results. And then also using the new CZT cameras, these new high efficiency SPECT cameras, you're showing the same benefit with revascularization as you get to more severe ischemia. So this totality of observational evidence now over multiple multi-center registries suggests that there's a benefit with revascularization. However, when you go to the randomized trial evidence, at least that's published through in the last 10 years, you can see both in the Courage trial, which was a North American trial, Canadian, VA and non-VA, about a third from each, and a Berry 2D trial, which was a type 2, same stable coronary disease population in type 2 diabetics. You see no difference in outcome between revascularization and optimal medical therapy. And this was surprising to a lot of us. So that open artery hypothesis did not translate into an improvement in outcome. And a lot of the criticism was put on the shoulder of that there really was minimal ischemia often in these patient populations that were enrolled. And often the ischemia was so mild that it was often not, was prognostically insignificant. And in some cases, patients were allowed to enter with anatomic criteria alone. So at that point, in 2009, there's concern that whether or not we had enrolled too low a risk of populations to demonstrate a benefit. And as all of you know, prompt revascularization is the standard for more acute evaluations of patients, more ACS evaluations. So, you know, is it that we needed to get higher risk ischemia in order to try to elevate that risk to be closer to that of an ACS population, try to get that higher risk patient population? Would we demonstrate a benefit? So those discussions went on for a while after both Courage and Berry 2D was published. And of course, this is Dr. Weintraub's research, which I think is seminal in the field, showing a prompt and durable improvement in angina, better angina control with revascularization. Not only that occurring at 1 year, but maintained through 3 years of follow-up. Now, certainly atherosclerosis is a progressive disease, and we would not expect anything you do today to manifest itself and have long-term findings beyond, say, 3 years, as you can see by equivalent anginal control. But this is a factor that you will see time and time again through the randomized trials, a consistent theme of prompt and durable angina control with revascularization. And considering the patient-centeredness of our world and the increasing importance of this for patients, this is not to be trivialized and an important component of understanding the evidence with stable ischemic heart disease. And of course, it wasn't just symptoms of ischemia, but also signs of ischemia. We published with Dr. Weintraub showing, looking at paired serial stress testing, that the patients randomized to revascularization with optimal medical therapy had a more marked reduction in ischemic burden at 1 year. You can see some nice example of that on the left, showing a pre-treatment patient with a lot of ischemia, and then at 1 year, almost a near normalization of their SPECT scan. Of course, I have to tell you, that second SPECT scan is done on medication, so it's different than what you would do in terms of routine testing. But of course, in this case, we are actually trying to see if their medications are actually reducing ischemia. So this is an important component of the methods. And it was not only just overall, this was a powered analysis to look at a reduction in ischemia. We saw a sign that the moderate to severe ischemia folks had even greater magnitude of improvement all around, suggesting that higher risk ischemia may elicit a different pattern than that which we'd seen in the Courage and the Berry 2D trials altogether. And of course, Berry 2D did not do a baseline study because they were afraid that there was just too much going on for patients that were being enrolled at the time of randomization. So they did a 1-year study, but the results are virtually identical. And of course, Berry 2D was not just PCI, but CABG as well. And you can actually see at 1 year, less ischemia in the revascularization arms for both PCI and CABG when compared to medical therapy. And you can see, if you look at the figure on the right, that most of the reduction was in those with higher risk ischemia, which is interesting to think about. And it goes to the general tenet that you see, the higher the risk population, the potential for greater proportional reductions, in this case, in ischemic burden. So another sign that there may be a different pattern or threshold that we could elicit in those folks with, in those patients with stable coronary disease and more higher risk ischemia. And of course, there's just 2 additional papers before I get into the ischemia trial, which are intriguing. Again, from Krishna Patel. Krishna Patel works with John Spertus, who was the inventor of the Seattle Angina Questionnaire. Krishna is a rising star in nuclear cardiology, and she published that prior paper that I noted. And here's a second paper from Krishna published in JACC last year, where she looked at the relationship between PET ischemia and improvement in angina with revascularization as compared to medical therapy. Again, observational findings, but again, very intriguing. Small sample, 300 patients with coronary disease presenting with new or worsening symptoms. And what you can see by this highlighted red at the bottom, for those patients that had moderate to severe ischemia, there was a reduction in angina frequency and overall improvement in the Seattle Angina Questionnaire summary score, again supporting the signs and symptoms can be improved with revascularization as compared to medical therapy. And I probably wouldn't note this trial, this paper, if I didn't also see the second paper come out from Orbita. Now, Orbita is, again, a very small randomized trial, single vessel PCI versus sham-controlled procedure, or let's just say placebo-controlled. Came out of the UK, and this is a secondary analysis from the Orbita trial, again using the Seattle Angina Questionnaire. And what you see on the x-axis is a stress echo wall motion score. Anything greater than 1 is an inducible wall motion abnormality. And what they showed in this analysis, which was published in Circ last year, is that patients that had an echo score of 1 or greater had an improvement in angina more often with PCI than they did with the sham controlled. And so this is interesting. Again, we put this in the intriguing category, but there's 2 papers now with 2 different modalities, 2 different settings, which I think show, again, are very consistent with the theme of evidence that we see in terms of improvement in angina with revascularization. Of course, I have to put a caveat to this with the Orbita trial, is that anytime you compare it to placebo, you're going to magnify those differences, and it's also a very small sample size, but it does add a consistency in the pattern. So where are we now? We see that revascularization improves angina and as well as reduces ischemia, so that signs and symptoms of ischemia are consistently benefited to the patient, but no improvement in outcome. But what about vessel-specific ischemia? What if we focus specifically on how we can actually use fractional flow reserve or vessel-specific ischemia? And the FAME trials come to play when we discuss this. And if we look at FAME 2, which was FFR-guided PCI versus medical therapy, we can see a marked reduction in the primary endpoint, the primary composite endpoint of all-cause death, myocardial infarction, or urgent revascularization at 1 year. Now, this trial was stopped early because of the DSCB was concerned about that increasing risk in the medical therapy arm. As you can see on this figure on the lower left, that red line, they were concerned about that, so it was stopped early. And the lone composite endpoint of this overall primary endpoint was urgent revascularization. Again, that theme about worsening angina leading to an urgency of revascularization. So that consistency of theme we see even through the FAME trials, even though most of the time it's interpreted as being quite different than the other trials. It is that thematically a consistent pattern that we see here. And these results were maintained through 5 years of follow-up, as we saw on a recent update to this a couple of years ago in New England Journal of Medicine. I would have to, by virtue of just being open and honest, also talk about MR-INFORM, which was a smaller trial of about 900 patients. They are patients with typical exertional angina, had 2 or more risk factors or a positive exercise ECG. The patients were randomized to receive stress myocardial perfusion imaging with MR versus an FFR-guided care. So the FFR side is basically FAME, if you will, the FAME trials. The MR is using stress perfusion imaging to select patients to go to angiography as well as to intervene on care. The patients that went to angiography from MR had a lot of ischemia, about 18% ischemic myocardium. So it's a lot of ischemia in relation to anything we've seen. So again, a higher risk population. This was a non-inferiority trial, which I find difficult to interpret. But the results were non-inferiorities between an MR-guided pattern of care, strategy of care, versus a FAME-type strategy of care, showing comparable safety between these 2 types of approaches. Again, adding to the support of a vessel-specific or a targeted ischemia vascular territory-specific care pattern for PCI. And so where are we? So we see this continuum of symptom and ischemia benefit, including stable improvement in stable angina, as well as improvements in unstable angina. But what about higher risk ischemia? Over the last 10 years, there's been that lingering doubt about the trials of whether or not we enrolled certainly sufficient number of patients with higher risk ischemia. And of course, the ischemia trial, by virtue of the fact that we were guessing on a lot of our design criteria, enrolled a lot more patients than we saw in the other two trials, and hopefully made it as robust as we could within the time period allocated. One of the things I thought, just for interesting of discussion, just to let you know, is what we wanted to enroll a lot of patients from a lot of different modalities, but we couldn't really understand how we could define a comparability. So we decided on using 10% ischemic myocardium with nuclear imaging, but how do we go for a comparability of risk with echo or MR, for example? And we decided to use a comparability in risk in terms of around a 5% annual cardiac death or myocardial infarction rate. We went to the experts in the field and we came up with these definitions, but they're all based upon a comparability of events. I think right now I'm doing an analysis is to see if I was correct. I don't know the answer to that, but this is basically some inside story as to how that was devised in terms of trial eligibility criteria for moderate to severe ischemia. About 2 years into the trial leadership wanted to make the trial as robust as possible. We added in exercise ECG. The criteria are here on this slide. You can see that particular patients had to have a history of angina, obviously had to have an ability to interpret the exercise ECG. So they had to have no significant resting ST segment changes. They had to have exertional on exercise, either horizontal or downsloping 1.5 millimeters and 2 leads. Even more if you could just have 1 lead criteria and ST elevation in a non-Q wave lead, obviously not trying to pick up wall motion abnormalities. These criteria had to be met at a lower workload. I still was worried that wasn't sufficiently high risk as the stress imaging criteria. So we made the stenosis a little bit more severe, and it had to be either a proximal or mid-segment stenosis on CTA. So whether or not that addition was truly a good idea or not, I think still remains in question, and whether or not those criteria were sufficiently robust to make that equivalent across the modalities, I think remains a question today. So let's look at the ischemia trial. So it was patients with moderate to severe ischemia. The site determined the amount of ischemia. They were overread, all of them were overread by a core lab. And if possible, if the patient's kidney function was sufficient, they did a blinded CTA. And I'm going to talk about, I think, some of the benefits of that in a moment. And the core lab interpreted eligibility, whether or not they had obstructive disease. But more importantly, I think the benefit of having a blinded CTA was to exclude patients with non-obstructive disease, as well as to exclude the unprotected left mains, which you would not want to randomize to a conservative strategy of care. Randomization to invasive versus conservative care before a cath lab presentation, which is important. Average follow-up, 3.5 years, about the composite endpoint, cardiovascular death, myocardial infarction, resuscitated cardiac arrest, hospitalization for unstable angina or heart failure, and some key secondary endpoints, particularly angina, which we'll talk about at the end. Now, if you look just at those eligible patients, here we see an analysis from Harmony Reynolds in JAMA Cardiology earlier this year, looking at the relationship with a nuclear scan, the echo scan, CMR, and exercise testing in women versus men in relation to identifying obstructive disease. And you can see the nuclear scan was very highly accurate. Not sure why the stress echo scan was not as great in terms of accuracy and identifying obstructive disease in women. These were more often hypertensive women. There have been several papers showing inducible wall motion abnormalities with uncontrolled hypertension, particularly with those in the setting of left ventricular hypertrophy. High degree of accuracy with MR. I think the lower accuracy in women with exercise ECG is consistent with what we would expect, despite having that higher threshold of a 70% stenosis. So I think one of the benefits of using CT is really identifying those folks with non-obstructive disease. And of course, we recently published within the last couple of months, the Credence trial, where we actually looked at using plaque characteristics to identify ischemia on invasive FFR, this kind of INOCA folks. Although in this slide, it is both obstructive and non-obstructive atherosclerotic plaque findings. So not just stenosis severity, even milder stenosis severities, 30–40% had an increased risk of a reduced FFR. Lumen volume, particularly in the setting of an increased LV mass, non-calcified plaque volume, the sequential mild stenosis, and also high-risk plaque features such as low attenuation plaque or positive remodeling, all were associated with ischemia in the cath lab. And I think this is important for us to realize that ANOCA is real. Ischemia in the setting of obstructive disease is real, but also is ischemia in the setting of non-obstructive disease. And there are really some consistent plaque findings. It's not just credence. There have been about a half a dozen papers focusing on that. So if you think about the ischemia trial as a strategy trials for non-invasive testing, you can actually see how CTA could be valuable in really clarifying the ischemia findings, particularly when it identifies atherosclerosis, where prevention, I think, could be particularly beneficial into guiding the intensity of management, particularly in the setting of a high burden of non-calcified plaque. So here's the baseline characteristics, and I would bet that all of you, when you saw this paper, there was a big flag that came when you read this table 1. And if you look at table 1, you'll see that left ventricular function, moderate to severe ischemia with an EF of 60%. Right away, you're starting to think, wow, these are not the patients that I would see. That I would be expecting maybe 50, 45%. You know, you couldn't enroll somebody with an EF under 35, but I would have expected that there would be some more patients with even modest LV dysfunction. So this is a different group of patients. And although most of the patients had angina, some did not. And most, about a third of the patients had either a new onset or a worsening frequency over the past 3 months. So this gives you some insight into the expected results. We can see about half the patients came in from nuclear, about 1 in 5 from echo, small amount from MR, which was disappointing to me, and about a quarter from exercise ECG. Here you can see the findings. As you look across any of the ischemia trial findings, please note on the far right that we only report exercise ECG as having severe ischemia. It was a kind of a yes or no, eligible, ineligible. And about 13% of patients had insufficient ischemia, which is a fair amount just to be concerned about how that particular noise may add into the trial findings. Some interesting and different patterns across the different modalities, but a lot of disease. Again, you know, we didn't miss, this wasn't a preponderance of single vessel disease. You know, 3/4 of the patients had multivessel disease despite having preserved EFs. You know, almost half had proximal LAD disease. So this is a population with a fair amount of disease where this is the core of secondary prevention in these patient populations. Looking at the baseline burden of angina, those of you not familiar with looking at SAC, although anybody working with Bill Weintraub, I can't imagine, doesn't know how to interpret a SAC score. Lower scores are worsening symptoms. But if we look really at the categorization, we can see that about 2/3 have angina. About a third of the patients did not have angina within the preceding month. So that's kind of an interesting group to include in this. Of course, 2/3 did, but some did not have a lot of angina, including some that only had angina several times per month. And I think these are important for as we think about stable coronary disease trials and the burden of angina in this population. Now, here is another interesting slide from the main trial findings, looking at baseline versus last visit risk factor management. So there was no between group differences between the two, but statin therapies, any statin therapy, were quite high at baseline and at follow-up. So and as well, you could say fairly good ACE or ARB use, improvement in high intensity statins, high use of aspirin or alternative, improvements in LDL, systolic blood pressure. Most of the patients weren't smoking. A huge improvement in terms of what was termed high-level preventive optimization. That's control of LDLs, blood pressure on aspirin, et cetera, as well as not smoking. But still, 40% suggesting that this trial was more real world than perhaps Courage, but also signs in here that the patients were well controlled at baseline. And as we've seen, I don't know, half a dozen, 10, 12 papers on pre-treatment, and particularly using statin therapies in the PCI group, how that influenced management in these patients, I think, is yet to be exhausted. Interesting findings about cath and revascularization use. If you look at the cath use, there were a fair number of patients early on that had an early event or OMT failure. It'd be interesting to know about what happened with these patients. And as well, we saw that about slightly more than half of the patients underwent revascularization within 6 weeks. And that suggests, even though they had moderate to severe ischemia, it suggests there wasn't a rush to treatment. And so this temporal sequence of patients with moderate to severe ischemia, I think is interesting, and it would be interesting to know. And a part of that is related to the fact that only 80% of folks in the invasive arm underwent revascularization at all. Half of those were because of insignificant ischemia, and about a quarter were because of too extensive ischemia with not any good revascularization targets. Lots of interesting data that I think we need a deeper dive into to understand the strategies of care which unfurled in these patients. Here's the main trial findings. I'm going to go through this quickly because I think all of you are well aware of these results. You can see those survival curves crossing, and that violates the proportional hazards assumptions. Part of the reason it took so long to publish the trial results is kind of the dialogue among statisticians about whether or not a Cox model could be used because of those crossing curves. You saw an early hazard here. You saw a late benefit, potentially late benefit. Overall results were not significant, but you see at about 6 months, a 2% increase. Of course, many of you know that that's procedurally related, and this potential late benefit in this separation of the curves. And the questions that kind of remain for all of us is early harm related to completeness of revascularization? If history would repeat itself, we'd say about a third of revascularization patients did not have complete revascularization. I don't know if that's the case, but certainly in some countries which were active in ischemia trial, complete revascularization is not necessarily the norm. So we really need that data. And of course, I think there's some interesting findings if that late benefit is sustained over a longer term follow-up, which has been proposed by the trial investigators. So potentially, if the findings are that potential early infarctions, procedural infarctions, were related to incomplete revascularization, and we can have a late benefit that's sustained, those findings would be interpreted quite differently than you probably interpret them today. And of course, here you see the results proposed in a different manner, showing higher procedural MI rates, a lower procedural spontaneous MI, again, completeness of revascularization versus late benefit. We need more information on this, I think, to clarify these findings, but they are interesting in terms of the findings related, particularly for procedural MI. There's been a lot of commentary and discussions about the routine use in clinical trials of monitoring for incident myocardial infarction, and I think that could be a part of our discussion here today. Looking at the heterogeneity of treatment, neither the baseline severity of ischemia or the severity of coronary disease were related to any heterogeneity of treatment, which was interesting. All of these curves cross that line of unity, and the p-values are not remotely significant. And here's just another way of looking at this. This was an abstract presented by Harmony Reynolds at the ACC in just recent ACC meeting. But I think you can see that, again, similar to Dr. Weintraub's findings, is that there was a prompt, durable improvement in angina with the invasive strategy. And this is obviously, as we said, consistent with stable coronary disease trials. If we want to look at this quite differently, I like to look at the probability of being angina-free. And I'm just going to take one point in place here, and that is a patient with weakly angina. You can see the probability of being event-free is quite different. It's about threefold higher with invasive care as compared to the patient treated medically or conservative care. And so if you get to the patient with no angina, there's no difference. And that's an important finding that we see. And as we see from 3 months to 12 months to 36 months, we can actually visualize not this prompt and this durable improvement in angina for all folks that had baseline angina, whether it be daily, weekly, or monthly, but no difference in the patients who were asymptomatic at baseline. And of course, this is really an important take-home message. And the patient comes to you and sits to you in front of you in clinic and says, what's causing my chest pain and can you relieve it? How can you make it go away? And of course, stress testing has been used very commonly over the past several decades to understand these symptoms, and how this interplays with these findings, again, is a question that we have residual in terms of the ischemia trial findings. And of course, I just thought it would be interesting to throw out some thoughts on trial design. And that has the first thing has to do related to this pre-treatment medical therapy patterns and how they potentially could have influenced the findings. And I think we have a lot to learn in terms of understanding and unfolding more of an understanding of patient-centered outcomes, asking the patients what they benefit, what are their goals in terms of seeing you, what are their goals in terms of management. And I think we have to think about the burden of angina in this patient population. I'm not sure a priori that all of us thought about the patient who was having monthly angina as being the typical patient that we would expect from the ischemia trial. And then we do have a huge problem on overestimating the effect size when we plan a trial. We look at the prior literature, the evidence, we estimate what the effect size would be, and consistently there is an enrollment of a lower risk population, or therapies have changed, times have changed, and we see this underestimated in terms of effect size and a lower than expected rate and a lower than expected event rate. And oftentimes we've heard in terms of the trial of a lack of clinical equipoise, which I think really has to be challenged within the community, is that if we're going to do trials, we've got to support them. We've got to try to prove a benefit. And so I just wanted to say, though, that I'm not sure that oftentimes people say stress testing is dead. Certainly from this guideline, ESC guideline, as well as the upcoming ACC chest pain guideline in 2021. There is a need to establish a diagnosis. There's a need to understand the ischemic burden, particularly when clarifying the patient's burden of symptoms, and to have an assessment of risk. That remains, and I think that's an important part of utilizing stress testing. So I think in summary, this is my summary slide, prompt invasive strategies don't reduce risk. I think we learned a lot about reinforcing that pattern of angina control. And I think we learned a lot about the value of asymptomatic ischemia. There was often this idea, if some patients have a lot of ischemia despite being asymptomatic, that they need to undergo revascularization, at least observationally. That's what was discussed. I think we learned a lot that those patients don't benefit from invasive care. And of course, people ask, how did they get into that strategy? I would guess that a lot of these are preoperative assessments, or patients that didn't have baseline angina, could be diabetic, those with neuropathies, et cetera. But I do think this does support a role for CTA in terms of providing an understanding of non-obstructive or ANOCA, as well as identifying patients that really need a very prompt care. So I think we're awaiting many more results. The ischemia trial is left up with a lot of residual questions. And of course, I think this is a good opportunity for me to open it up and for us to have discussions. So thank you all for your attention.
Great. Thanks so much, Leslie. That was a wonderful talk and a great summary of, as you said, 20 some odd years of data. And I find it interesting how many questions we have on a topic that's so central to cardiology and that we've been studying for as long as we've been doing cardiology in the way that we know how to do it now. I'll open the floor for questions and discussion. We've got plenty of time.
Leslie, it was a wonderful talk as expected. And you kept quoting this guy Weintraub. I have no idea who you were talking about. But thank you for that. And it's great to see you, even if it's just a Zoom. So I just want to point out one more thing about the ischemia trial. I think everyone here knows, and you know very well, that also but you didn't show it. There was no mortality benefit. The mortality curves were absolutely superimposed. And that undoes, at least to some extent, the potential benefit of preventing spontaneous MIs. There's an extension of the trial, and we will be gathering data both on MIs and mortality, and so we'll learn more about that interplay in the future. My question to you is, you rightly focused, you talk about ischemia. It was really the subject of the day. But there's another way that we evaluate coronary disease, of course, entirely, and that's angiographic extent. And both in COURAGE and in ischemia, angiographic extent is prognostically important, more important than ischemia. And people will increasingly be using CT, but also CT with FFR to look at the interplay between ischemia and angiographic extent in deciding on revascularization, as opposed, in addition, of course, to the overwhelming importance of the severity of angina. So maybe you can talk a little bit about your feelings about the interplay between angiographic extent and ischemia in decision making.
You know, I think in COURAGE, there's a paper that's ongoing, as you know, Bill, showing ischemia is not predictive of outcome in the ischemia trial results. And I think a lot of that has to do within our traditional analysis. The normals allow us to magnify the risk. When you take the normals out, or the patients without disease, you don't get that stratification of risk. I think at core of our understanding of risk is based upon the extent and severity of luminal stenosis and the extent and severity of atherosclerotic plaque. Those are fundamental to driving risk, as you so eloquently stated. And I do think there is a fundamental difference between myocardial ischemia and vessel-specific ischemia. And that's where FFR is a real strong added value on that. I think when we get out into the myocardium, there's a heterogeneity of reasons why ischemia could make manifest. I think most notably is in the frequent patient with hypertension, a larger LV mass or LVH that's manifesting itself in ischemia, or a whole array of reasons, cardiomyopathies, et cetera, which can be manifest. And it makes the interpretation of ischemia, myocardial ischemia, very, very challenging. And whereas vessel-specific ischemia, I think it's more specific to what's going on within the vessel and the plaque burden, the stenosis burden, whether it be expansively remodeled or negative remodeled. I think it can inform what the burden of angina is in terms of that downstream subtended myocardium. I'm a huge fan of FFR. FFR-CT has, the methodologies have kind of evolved over time. They used to take the more distal measurement, which, as all of you know, that artery tapers and gets smaller and smaller, as most of the CT world will say. If you measure down so distally, you may get a significant FFR just by virtue of the size of the vessel. So the methodologies have changed. It's become more robust. And I will actually tell you that we are proposing a reanalysis of the ischemia trial data to look at FFR-CT as well as to look at plaque burden, so we can try to look at more non-obstructive predictors of any of the endpoints, but also see how FFR-CT could be used to guide care and how it may have been more efficiently used, because you know it's processed at the same time. I'm not a salesman for this, but I do think if we can make our lives easier, it might be advantageous. Of course, we don't know that. That's just speculation. I do think it adds value, although it is expensive. As Dr. Weill will tell us, it's an expensive addition to the armamentarium. It's about $800 added benefit. But I see a future where we can incorporate that. I also see, you know, if I look at the FFR-CT data, I also see that we can actually understand more our myocardial ischemia results. You know, we've been looking at the relationship between FFR ischemia and myocardial ischemia, and showing that we can get more milder changes with the gradation of FFR-CT along the artery, which can clarify the relationship between a non-obstructive and obstructive stenosis, and understand those milder patterns of ischemia, which may be misleading to folks in terms of over intensity of utilization or a follow-up care of patients with more milder ischemia. Long answer, I'm sorry. This is an area of interest of mine, so I could really go on and on and on this. I find it fascinating, Bill.
May I ask a question? That was a beautiful, Steve Epstein, that was a beautiful, beautiful talk. Let me give you my take on this, which I think you've come to after the trial, and that is ischemia is a marker of depressed flow, but it really, based on the original Courage trial and now the Ischemia trial, it doesn't indicate irreversible changes, death or myocardial infarction. The FAME trial repeatedly talked about the benefit only was caused by revascularization rate. It did not, using the FAME strategy of FFR, it did not decrease mortality or acute myocardial infarction. So all of the data now, after many, many years, would seem to me to indicate that documentation of the presence of ischemia, it does not indicate probability of an irreversible outcome, acute myocardial infarction and death. If somebody has severe ischemia and they have angina, of course, there's no debate, they should have revascularization. My question to you is, and I haven't heard this much from your talk, is what about vulnerability to plaque rupture? Because after all, that's what causes acute myocardial infarction and death. So all of the extraordinary data that you have, is there any way that you could have markers of plaque vulnerability or patient vulnerability? Because there are so many plaques that rupture that are not significant in terms of flow limitation. So what about vulnerability, which I think is absolutely essential to identify the patient who is at risk of an irreversible outcome? What do you think?
Yeah, no, it's a fantastic question. And I think one of the reasons why we're trying to submit this application, we've gotten approval for to submit the application for additional funding for ischemia. And you're exactly right, is to look at concordance and discordance between myocardial ischemia within the same vascular territory in relation to plaque markers of vulnerability. And of course, we don't have OCT or IVUS in these. We're going to have to use CT markers, but a large non-calcified, particularly very low attenuation plaque burden, particularly in the setting of a positively remodeled or negatively remodeled, but a huge technical term chunk of non-calcified plaque, particularly if it's that really low attenuation plaque. We're also looking at, and I should have mentioned this before, but there's also a novel marker that looks at fat attenuation, pericoronary fat attenuation, what's called this perivascular fat attenuation, or this Hounsfield unit density shifts in the fat around the artery, which is a marker, which is purported to be a marker of inflammation. So one of our ideas is to look at those arteries that have a lot of non-calcified plaque, that are highly inflamed, at least based upon the fat attenuation index, and to see how those arteries behave. What's the relationship to ischemia, if any? I would guess it's concordant, but not necessarily with a fair amount of discordance, I would guess. But also to look at those particular arteries with CTA, and particularly to try to identify vulnerability relationship. We've to incident myocardial infarction, ACS as well. We've published a couple of preamble series to that, one in JACC a couple years ago, looking at CT precursors for ACS. A lot of the CT literature is trying to emulate what has been done invasively in order for us, kind of like a prospect, if you will. But it's exactly to try to look at that and to try to emulate and try to identify vulnerability in that, look at the relationship to ischemia, and then try to do that. And that's the goal of that application. We don't have that information in ischemia. One would guess that that would probably be much more accurate in terms of understanding risk than what we've done.
Did you store blood in these patients?
Yes, but not all of them. A small amount. I'm not sure I recall the number. I don't know if Bill remembers, but it was less than half of the patients.
Thank you.
Thank you.
This is Ron Waxman. The invasive study taught us that the lipid-rich plaque and plaque burden are very good correlates with future events. And we demonstrated here with the LRP study, and Greg did it with plaque burden. Now, CT today can actually detect probably both. There is some also new software competing with CT-FFR. It's a different company that does have option to look at morphology on lipid-rich plaque, and if it's not ready today, it's going to be ready soon, and plaque burden as well. So why not to take those images instead of doing it? What we're doing is secondary prevention, but as you do this under the ischemia, even within the ischemia trial, and to look on plaque burden, lipid-rich plaque, and see if they correlates to those who actually had an event, because you have the patient had an event, you have CT on everybody, and now you can see if they match the correlation.
I agree totally. And I think that one of the issues is, but it's not a problem for you all, one of the issues which Dr. Weill will chime in on, as well as Dr. Taylor, is with CT, you need good image quality in order to get that resolution down, and for folks that you don't have good CT image quality. And that will be an issue with ischemia, because a lot of these CTs were done a while ago, and they're done from non-expert centers. And so we do have about 20% poor image quality. So we're still trying to ferret that out. And of course, the challenge that we have is, will we have a sufficient number with really good image quality? There are now 2 FDA approved software packages to do. By the time we get done with this, I'm sure there'll be 4 or 5. There are several ways to do FFR. I think that's good for the field. We can drive the prices down and to try to do this more affordably. I do think image quality will be an issue when you're trying to look in more detail than whether or not you have a stenosis, yes or yay or nay. When you're trying to quantify plaque, it's going to be more of a challenge. You get artery wall in there close to the plaque burden. Some of these densities are all get kind of mixed up. Another technical term, but I think there still will be a sufficient number in there to identify the low plaque burden. We've got a lot of groups have a lot of experience with this, and hopefully we'll be successful with our application with the ischemia trial.
Thank you.
Thank you.
Dr. Shaw, this is Hector Garcia. A wonderful presentation. I learned a ton. Question and a comment. The question is related to the definition of spontaneous MI that is used for the primary endpoint. I'm rather surprised to see that type 4B and type 4C are included as spontaneous MIs when they are actually stent-related complications. One is stent thrombosis and the other MI is related to ISR, in-stent restenosis. So I see clearly a disadvantage comparing the 2 groups by using those stent-related complications, because by study design, one, the invasive arm, always gets a stent, or that's at least the plan, and the other is not getting the stent. So the likelihood just there for getting one complication versus the other is more for the invasive arm. So in general, I'm surprised to see that those 2 types of events were included there. And that's the question part. Maybe I'll stop there and then I'll make my comment.
Okay. Yeah, thank you. This was a lot of work in terms of trying to figure out how to categorize these myocardial infarctions. One that took several months of heated discussions about which different groups to put in what, to try to be fair to the interventionalists, to try to identify what was remote from the procedure, et cetera, what were the thresholds for procedural infarction, et cetera. I think, suffice it to say, I think the short answer is we cut this a number of different ways, and it doesn't change the overall findings as you see them presented here today. But I think the issues around a procedural infarction driving part of a component endpoint in terms of disadvantaging an invasive strategy, I think has been the focus of much discussion. Those of you on this Zoom call, I think will much more experienced than I am in that side of the equation, and I think could provide commentary around that, but I think it's well taken. I think it's just interesting to see how we learn from each and every trial and try to resolve these issues, but certainly it didn't really change the findings as it would be presented.
Yeah, thank you. And the comment is related to the concept, the background of the study. So in the PCI literature for stable populations, most of the studies have aimed at reducing angina burden. And that has been very well characterized. And we know already that PCI in stable patients is not going to reduce mortality. So your main aim is to really relieve symptoms and angina burden. It's surprising that you start already with 1/3 of the population without angina, when again, the main objective for PCI in stable patients is to reduce it. And then we also know from repeated number of publications that 1 out of 3 patients that receive stent in the context of stable angina remain with angina burden. So it's quite surprising to see that one of the main aims is to test whether you can reduce further angina, but you start already with 1/3 without angina. And we know already that 1 out of 3 of those receiving the stent would remain with angina. So I'm struggling to understand the real rationale of the study when basically you upfront are losing in terms of improving angina symptoms.
To me, that's one of the biggest criticisms of the ischemia trial. You know, my job was to monitor, I'm not turfing this, by the way, I'm not turfing this to somebody else. My job was to monitor ischemia eligibility. But I think you're absolutely correct. I even would put those people with monthly angina in that category. I'm not sure that you would, you worry about control of somebody who's having angina maybe once a month. I'm not sure that that's the same as somebody who's having daily episodes, or there's a crescendo type pattern, any kind of worsening symptoms. And particularly as you think about that patient with moderate to severe ischemia, where you think about some acuity of risk in that population. I think that's a huge criticism for the trial and I actually was shocked when I saw that number. I'm like, wow, and I think, the retort from others in the investigators was that there was concern about asymptomatic ischemia. I think in the United States, the vast majority of those patients, if you think about an appropriate use criteria, how did they get to a stress imaging lab? It's kind of challenging to think about. Some of them would have been preoperative assessments, I guess, but it's not a typical patient population that we would see here that is asymptomatic and then goes to a stress test unless there's some other evaluation. I think that is the main criticism, at least in terms of my perspective, of why they were in the trial and why and how much noise they added.
Thank you.
Leslie, it's Alan. I had a nice question for you, and thanks so much. Good to see you. I had a question. GDMT was a common theme through both arms, right? And I'm wondering what learnings can we expect there? During the conduct of the trial, LDL goals changed, blood pressure goals changed, new diabetic drugs became available, aspirin came under scrutiny, DAPT evolved. Are we able to learn through ischemia what GDMT really is for these patients across both arms, and if that actually interacts with the outcomes of an initial conservative or invasive approach to revascularization? Because no matter what you do initially, it's something we can all get behind is, prevention remains an important part of all these patients and their management.
Alan, I think that's a great question. We're trying to do a deeper dive on that right now. I think particularly conservative management, I have a paper that's approved to try to look at that. What does it mean now? If that's supposed to be our mainstay, how is that actually manifest itself in the trial? I think a couple things is, we have to understand better adherence, pre-treatment adherence, pre-randomization adherence, who was in that category, what were the adequacy of care in terms of meeting guidelines. We have some inference from some of the analysis, but we don't have an idea. They developed this high-level preventive optimization, but I'm not sure that it really gives us an idea of who was actually at target for each of those. It just says who was at all of those targets. And I think in terms of understanding it, I personally find that to be a prime area in terms of understanding medical management. I will tell you that there were no differences in the invasive arm versus the medical therapy arm in terms of each of those targets, blood pressure, et cetera. I do know, and the other message that Dr. Weintraub will comment on as well, is that the Courage trial was criticized for being very case managed and very protocolized. It did not emulate real world, and I don't think you can say that to the same extent for ischemia. It was much more let people go. We provided them with feedback in terms of which patients were at target, detailed, specific, patient specific as to who was at blood pressure target, who was at, and those targets were changed given different guidelines along the way, different availability of medication, et cetera, was made available. And discussions were put forth on any new drugs that came to market. So it is what happens in a trial. Things change, and it's often hard for the trial to actually pivot with that new evidence. But I think that's the nature of these larger, longer trials, these 7-year trials.
Thanks, Steve.
What percentage of your patients had stress echo?
That's about 20%.
And among those, I guess it's probably too few, but one of the biggest prognostic markers from stress echo is cavity dilatation. Do you have any information from that particular parameter?
We do. We published a paper early on, and that Mike Picard was the Core Lab, Echo Core Lab PI. Mike published a paper early on, just some observational findings of use looking at LV dilation, and I think that is slotted to be analyzed, where Mike is the lead on that, and we'll hopefully try to find some. We actually have a call of it later this week, but I think it will be important to try to look at other more novel factors from the imaging modalities, which may add uniquely. And I think that's one, particularly around some of the harder endpoints like heart failure, hospitalization, et cetera.
Hi, Leslie. Good to see you. And thanks so much for the great presentation. I guess I'm going to tag on to Dr. Goldstein's because my question is also about the left ventricle. And I guess we, kind of the cartoon version of thinking about ischemia and non-ischemia, obstructive and non-obstructive disease. Sometimes we forget about, the ventricle that's downstream. So what do we know about differences from one group to another in terms of things like left ventricular ejection fraction or left ventricular thickness and hypertrophy? What have we gleaned from the studies?
Well, it's a good question. We know that these are largely folks with normal EFs, which is interesting. The average EF across the two groups was about 60%. And so they are of all those folks with a lot of ischemia, they are the lower risk group. We don't know anything in terms of, if I'm looking at the numbers, I'm going to guess that 15–20% maybe had EFs under 50, but that's not a lot of folks for us to think about, how that could impact their outcomes. Certainly that's a group that we are trying to look more at in terms of understanding. One of the challenges is the EF data that I have seen today has largely been from basically from electronic health record or the site determined. I'd like to see some of the imaging data confirmed ejection fractions, which I think could be more definitive about what happened for the patient at the time of enrollment and randomization. It might be more quantitative than a more qualitative assessment of EF.
Thank you.
Thanks. See you, Guy.
Thanks, Leslie. That was really a great discussion, and I'm sure we could keep on going, but I can't help but take moderator's privilege and ask just one last question, which is the spontaneous MI data. So you showed that, the procedural MI versus spontaneous MI. What's your take on spontaneous MI? What are we going to learn about that and the impact of revascularization versus medical therapy to prevent that? Steve Epstein said something about ischemia doesn't portend an irreversible issue. The spontaneous MI raises the question, well, is that true? And what do we know about these spontaneous MIs?
I'm not sure that we're going to look. I mean, to me, the burning question is the completeness of revascularization and the procedural MIs. That's, to me, the big burning question is how much did they leave behind during that index revascularization procedure? How much was not touched? But I think the spontaneous MIs, because I think Dr. Garcia talked about the admixture of these type 2s and with, type 4, it's hard to kind of wrap your head around what's going on in that. And I think the long-term findings, if we could see amassed more than 40 here, 30 there, I mean, it's kind of hard when you throw all these numbers together. It's basically procedural versus non-procedural. I'd like to have a deeper dive into what that means. I think what was really well stated today is this kind of disconnect between the myocardial ischemia and more prominent permanent damage, how this manifests itself in terms of long-term results. It would be interesting to see if these curves continue to separate, how much this is impacted by spontaneous MI, unstable angina, heart failure differences, et cetera. Not many that resuscitated cardiac arrests in this group. I think there are about 16. So the vast majority of events that are going to be looked at are going to be those types of ACS type, and it will be a longer term follow-up is really going to be needed to try to get a better understanding of that heterogeneous group. Not really a good answer.
I mean, I think that, as I said, thank you so much. This was great. And there's going to be just so much more to learn from ischemia, such a large trial, so much imaging data, so much clinical data. I'm sure that you all will keep on teaching us about what all of this means in this disease that we really take care of every day. Thanks again, Leslee. Very much appreciated.
Great to see everybody. Happy holidays, everyone. Take care.
Take care. Bye-bye.